Well, good morning. My disclosures. I'm involved, what's pertinent to this talk is the company Dysgenics that I'm involved in, and it's been an outgrowth of some of this research. So as Langston just mentioned to you, and you all know, lumbar degenerative disc disease is incredibly common. Not always symptomatic, but when it is, it's a big problem. So much of a problem that it's incredibly costly. Back pain is the second most common reason that patients visit a physician, and it's the number one, chronic back pain is the number one cause of lost work days. So it's been estimated that it costs over $100 billion annually just in the US to treat this entity. And we all know that we treat around this entity, but there isn't currently a way to repair or regenerate a degenerated disc. So that's some of the genesis of this work. I'm going to start with some very basic science and hope not to bore you. So the disc, you know, is basically a shock absorber. And what's key to its shock absorbing function is its ability to be a hydraulic entity. So the disc bears axial loads and then distributes them radially. And your annulus is built like a tire with bias plies. Very interesting. So these tissues are mainly water. Your nucleus pulposus is almost 80% water, a healthy nucleus pulposus. And even the annulus fibrosus is 70% water. So that water is critical to the function of that disc. Now within that hydrated environment, there is a sparse but active cell population. There are living cells called nucleus pulposus cells. And they live with some other constituents in the extracellular matrix of the nucleus pulposus. So there's an interaction that goes on between the elements of the ECM and the MP cells. And the proteoglycans that are within the nucleus are the key to the hydraulic function of the disc. So the proteoglycans have negative charges. They attract sodium ions, and this is what sets up the osmotic gradient that keeps a disc hydrated. When your disc loses the proteoglycans, this starts a whole process of progressive degeneration of that disc. The disc can't hold on to water anymore, and trying to hydrate it won't work. It doesn't work. Interestingly, people have tried to equate the disc with collagen. So the nucleus pulposus is not cartilage. There is cartilage, of course, on the M plates, but MP, for example, one difference, if you look at the ratio of proteoglycan to collagen in the nucleus pulposus, and there is collagen in both cartilage and in nucleus pulposus, but the ratio of proteoglycan is 27-1 in the MP and only 2-1 in cartilage. And so that just tells you how important that proteoglycan is, again, to the functionality of that disc. There is also collagen, as I just spoke about, within your disc. There's collagen 1, mainly in your annulus, and it's there for structural purposes. And there's collagen 2 in your nucleus, and the collagen 2 really serves not so much structurally, but to help confine and aggregate the proteoglycan, and this helps the disc hold on to water. The disc, the MP, is also a dynamic environment, so it's hypoxic. It borders on acidosis. It's minimally vascular, as you all know, so it's a challenging environment, but it's metabolically active. There's a low-level metabolism going on in a normal disc that actually upregulates when the disc degenerates. So there's a constant production of the constituents of the extracellular matrix by the MP cells, by the normal MP cells. And then there's a process of breakdown. So there's a balance between anabolism and catabolism there. So-called matrix metalloproteinases break down elements of the ECM like collagen, and there are even specific proteins whose job it is to break down the proteoglycans. The ADAM-TS proteins, for example, are there to regulate aggrecan. Aggrecan is the major proteoglycan in your disc. So that balance of anabolic activity and catabolic activity gets out of whack, so to speak, as the disc degenerates. And that leads to a progressive loss of hydration, a progressive loss of structure, and eventually an inability to sustain the normal biomechanical loads. So if we're looking at trying to treat this entity, symptomatic degenerative disc disease, a couple of targets that would be logical targets if you think about the normal structure and function of the disc. One is to improve the extracellular matrix. It's there for a reason. And so if you could improve the ECM, that's of potential therapeutic value in the disc. And so as the ECM breaks down into fragments of collagen and fragments of aggrecan, there is an inflammatory reaction to this, and there's an upregulation of various inflammatory cytokines. The major one is TNF-alpha, but there are a whole host of them that get upregulated, as you can see from this slide. And so we know that the disc, as it degenerates, has a component of inflammation, and that inflammation may be a reason for why some patients have pain with degenerated discs that are seen radiographically, whereas others have painless discs. What also seems to happen as a consequence of that inflammation is a reactive innervation. So normally, the annulus is minimally innervated, but we know that in inflamed discs that there's ingrowth of neural fibers, and some of which subserve pain. So you've got this process where the disc no longer is that nice hydraulic shock absorber. It's deteriorating. It's structurally deteriorating inside, and this leads to an imbalance of catabolism over anabolism. It leads to inflammatory consequences, and it leads to potentially painful innervation. So these are some of the cytokines that are upregulated in an inflamed disc. And so another target, besides normalizing, another potential target to treat this problem is to target the inflammation that we know is present in the painful disc. And so we all use anti-inflammatories, sometimes steroids. We know that intradiscal steroids really don't work well for this process, but we need something better to treat that chronic inflammation. So one possible way to attack this problem is through cell therapy, with the thought being that if we could provide functional cells into that disc, we could do a couple of things. We could potentially regenerate extracellular matrix, especially the aggrecan and the other proteoglycans that we need to literally pull water and retain water in that disc, along with the collagen too, to retain the aggrecan. But also for the paracrine functions of those cells to help rebalance the imbalance between anabolic and catabolic activity, and also potentially to mitigate the inflammation. Basic cell therapy 101, you can do autograft, you can do allograft, you can do xenograft, tissue from another species. So autograft, big advantage is there's no risk of rejection, right? They're the patient's own cells. There are some limitations, though. You have to harvest them from the patient. It's hard to scale that process if you're looking at treating people. And there are a number of kind of interesting things going on in the world of disc therapy where people are actually manipulating these cells in a way that truly isn't FDA compliant, and claiming they're using what are called the 361 regulations, the tissue regs, to try to claim that, oh no, we're not minimally manipulating them. So another possibility is to use allogeneic cells. And their drawback are the potential immunologic issues, rejection and the like. But the benefit is that you can manipulate these cells. You can make something that potentially would be available off the shelf. So it turns out that other people have had these same thoughts, and there have been a number of efforts over the years to use different cell types to try to address this clinical problem of degenerative disc disease, including all the cells I've got listed there. So when our group approached this problem, we first started about a decade ago, and we pursued a cell type that is a novel cell type that I'll go into some more depth about. So the cells that we use are actually derived from adult human disc tissue. And where this came from, it came from research at the University of Tennessee within the Department of Neurosurgery. And a Russian stem cell scientist, Valery Kukakov, who had expertise and years of experience with deriving pluripotent so-called stem cells from the adult human brain, was active in our lab, was at University of Florida with Al Roten for a while, and then came back to us. And one day we challenged Valery to see if he could do what he was doing with brain tissue with the human disc. We all know the disc is derived embryologically from the notochord, so there's a relationship to the CNS. And we were curious as to whether or not the culture processes that he had elaborated and gradually improved could be applied here. So it turned out it could be done. So initially the disc tissue came from my patients when I was going to do an ALIF or a TLIF, something where I was going to get a lot of disc tissue, and it's obviously done under IRB with human consent. I'd bring the disc tissue over to Valery's lab, and he would culture it and put it through his process. And so that's where these cells came from. So having derived those cells, there have been years of work to characterize them and to study them. So it's an interesting cell population. If you look at their cell surface markers, they're different from native nucleus pulposus cells. For example, CD24, it's highly expressed in native MP cells, hardly expressed at all in these discogenic cells. These cells have stable karyotypes after they go through our culture process. And at least in vitro, don't form tumor. Very important. You don't want to have a cell, of course, population that could do that. They're not immortal. Cancer cells are immortal, and they don't produce telomerase enzymes. It's a good thing. It also leads to them not being immortal. After we process them and then culture them and reculture and expand our cell population, the karyotypes stay completely stable, so important genetically. And beyond the lack of tumor formation in vitro, we've also studied them in vivo. In fact, this study that I'm showing here was done in a GLP fashion, good laboratory practices, in anticipation for doing an FDA clinical trial. You've got to prove to the FDA that your cells are safe in a variety of ways, and one way you do it is in an animal model against a control. So the control in this particular study were HeLa cells, Helen-Lane cells, the immortal cervical cancer cells that are used all over the world. And so the cells were injected subcutaneously in a population of nude mice, and 10 of the mice got HeLa cells, 10 of the mice got discogenic cells, 10 of the mice got our carrier, which is hyaluronic acid. And in those groups, neither the vehicle, the carriers, injected mice, or those injected with the discogenic cells developed any tumor. And the HeLa cells, all of those mice had tumor formation where the HeLa cells were injected. So positive control as you would expect. Interestingly, though, even in the subcutaneous space of a mouse, and remember, these are xenografts for our animal studies, so we did not use animal-derived discs to produce animal-derived discogenic cells, even though we could. We used our human cells in all of our animal studies. And so we saw the disc-like formation subcutaneously. And this next slide, if it'll show up, see if I can advance. Yeah, that's subcutaneous. You can see the cutaneous tissue of the mouse there on the surface. And inside, that's forming discs subcutaneously from the discogenic cells. So an interesting side finding in our study that was really to look at whether or not these cells had tumor-forming potential in vivo. So these are what are called oligopotent cells. So they're multipotent, but they're not pluripotent. They can be driven to certain other tissues. We can derive bone with using certain conditions in our culture media. We can derive cartilage. We can derive fat, but preferentially these cells mature into normal appearing and acting nucleus pulposus cells. And even in culture, they begin to form the constituents of the disc ECM. So the green there is aggrecan, the purple is collagen 2, and then there's also an actin cytoskeleton. That's the white. That's a cluster of discogenic cells taken from one of our cultures. So the cells produce ECM. They also have some other interesting properties. So I mentioned that the cell surface markers change when we put them through Kukakov's culture process. They lose their HLA markers, which turns out to have some salutatory effects. So one way to assess whether or not a cell is going to incite an immune reaction is to do a so-called mixed lymphocyte reaction. So you take mononuclear cells and some stimulator. So if the cells that you're using invoke an immune response, you'll see a proliferation of the mononuclear cells, and you can quantify that using BRDU and a fluorescence assay. So when we add discogenic cells to a mononuclear cell population from an unrelated animal, we see a mitigation of that graft versus host response. So speaking for the fact that these cells tamper down the immune reaction. And a way to assess whether or not your cell population is inherently inflammatory is to do a so-called two-way MLR. So in a two-way MLR, you take two unrelated mononuclear cell populations that have BRDU in them. And of course, if you pit two unrelated mononuclear cell populations against each other, they proliferate. And so that's the blue bar there. You add cell populations A and B, or A and C and B and C, you see an increased expression of BRDU because the cells are proliferating as they fight each other. When we add discogenic cells to that mix, we mitigate that response. So those basic lab studies hint at the notion that the cells are inherently anti-inflammatory and immunomodulatory in a good way. So what we know about the cell population is it's unique. These cells aren't present in large quantities in an adult human disc, just like stem cells are not present in large quantities in the human brain, but they're there. They're in the paraventricular white matter, and they're in the olfactory regions. And so you can identify them and expand them with the proper culture techniques. Basically what we're doing with disc is taking the disc and then deriving the progenitor cells. They have stem-like properties. They're not immortal. They produce ECM, and they can mitigate inflammation and immune response. So you go from the lab into animal studies, again, in anticipation of trying eventually to get these things into humans. And so the laboratory models of degenerative disc disease involve some kind of injury to the disc. In a rabbit, you'll produce what looks both radiographically and histologically like degenerative disc disease simply by puncturing a rabbit disc with an 18-gauge needle. As you move into higher order animals, you have to do a bit more. And the only note of caution here is you're creating something in the lab that looks like DDD, but it's not really DDD, right? This is a reaction to trauma. There's something to keep in mind, though, for people who, the surgeons in the audience, when they're counting discs, who like to stab the discs with needles, to say, well, I'm going to mark it. I never do that when I mark. I point something at it and get a floor image, because it is amazing what happens to a disc after you've punctured it. It was potential bad consequences. So one of the ways you can follow what's happening to a disc where you've induced this model of degeneration is it loses height. And you can quantify that through something called the disc height index. The DHI counts on the fact that the vertebral body is not changing. So it's a ratio between the height of the disc and the height of the vertebral body, because of course the radiographs aren't scaled. But it allows you to very precisely follow what's going on with those disc heights in a sequential fashion, as these things are sequentially x-rayed as we follow them. And you can also look histologically and with MRI, some other tests as well. So this is a validation in our lab of the rabbit DDD model. So at time 0, you puncture the disc, and typically you have control discs too. So the light blue line at the top is the stable disc height index of a disc that's been exposed but not punctured. The darker blue line, medium blue, is what happens to a disc that's been punctured. In the New Zealand white rabbit, within 2 weeks, that disc has lost a significant part of its height, and that whole process stabilizes at about 6 weeks. And if you look at these discs histologically, they not only shrink, but they develop little crevices, voids. The nuclei in the MP cells become pycnotic. The cells themselves shrink. And when you stain for things like collagen II and aggrecan, those ECM constituents diminish. So we have studied the cells in a variety of animal models. First, in our lab, in a non-GLP fashion, just to do some basic science, and then in anticipation of going to FDA in GLP fashion using a contract research lab, a CRO. And so we've studied the cells not only in rabbits, but in pigs and in Japan in dogs. In fact, Japanese PMDA, their FDA, the Pharmaceutical and Medical Devices Agency, actually insisted that the cells be separately studied in the Japanese canine model before they would allow us to initiate a trial in Japan. We shipped the cryopreserved cells over there, and they were able to reproduce what we were seeing here in the lab. Always good to know. As you guys probably know, when you try to reproduce animal studies in someone else's lab, about half of the time you can't reproduce the results. Calls into question whether or not the science is good. So when an independent lab reproduces your results, that's at least somewhat validating. So this is the GLP study that we had to do again for the U.S. FDA to work on initiating a human trial. This was 24 New Zealand white rabbits, and we used 2 cell doses. Four cell doses, as you see there, between 3,000 at low dose to 100,000 cells, and then with control conditions. So Rabbits got not only a cell dose, but there always is an exposed but unmanipulated disc, and there always is a disc that's treated with the carrier alone, the scaffold, which is hyaluronic acid. Discs are initial surgery through one retroperitoneal approach. The target discs, both control that are going to be punctured and control that ultimately will be treated, are targeted. We wait a couple of weeks to give the model of the degeneration to occur, and then go back in and then treat. Obviously, there are untreated controls, but there are also discs treated with one of these cell doses or with the vehicle alone. And so after injury, you see the histologic change. You see how the disc collapses. You see the clefts. You can kind of tell the nuclei are pyknotic there. I'll show you some higher magnification histology in a moment. And on T2 weighting, the typical dehydration of an injured disc. So one of the things, obviously, you're very, very interested in is, are your cells safe? And because our cells are allograft in humans, xenograft in animals, one of the major concerns is, are you going to see an immunologic response when you inject these human cells into these animals? And thankfully, we have not seen any signs of that in any of the animal models that we've used. And if you look at the disc height index, this is what we see consistently in our studies. So again, the top line is just the exposed but uninjured control. The bottom lines are a disc that is a positive control, stabbed but not treated, and the population of discs that are stabbed and then treated with scaffold alone. So statistically, treating with our carrier HA, because one pertinent question is, will hyaluronic acid itself do the trick? We don't see that. The HA doesn't seem to do much of anything. But consistently with the cell doses, we see a ramp up in the disc height. And typically we get somewhere around 85 to 90% of the original disc height. So not quite back to normal, but definite restoration of height. And histologically, this is what we see. So the HA-treated discs look a lot like the injured control. I'll show you histologically. You can actually see the HA fill in the clefts. We just don't see a cellular response. But with the discogenic cells, we consistently see a more normalized histology after injury. And so there's a close-up of the histology. So up top left, you see a normal control disc. You see the pyknotic nuclei and the increased density of the cytoplasm and these condensed nucleus pulposus cells on the right at the top. With HA alone, you still see the pyknotic nuclei, and you can kind of see the fill of the HA in between it. And then when we use our discogenic cells, we see that cell population turn into a more normal, plump-looking, healthier MP-type cell. And we also see changes in a good way in some of the ECM constituents. So here we're looking at various constituents of the disc. So if you look at the proteoglycan, for example, you see significant improvement approaching the normal disc, not quite there in proteoglycan and in the collagen too. So a variety of other studies that we've done in preparation for the human trial. So we've carried a couple of our animal models out to 6 months. In the New Zealand white rabbit, for example, the lifespan is 2.5 to 3 years. So 6 months in a New Zealand white rabbit is a good bit of his or her lifespan. We cryopreserve these cells, and so you have to prove that you don't alter these cells with cryopreservation. You have to prove that you retain potency after the cryopreservation. And we went so far, as I said, to ship cryopreserved cells, actually FedEx them to Japan for their study, rather than producing the cells in Japan itself. We've produced multiple cell lines. We've looked at lots of dosing ranges in anticipation of the human trial. And again, we thankfully haven't seen inflammatory changes. We haven't seen signs of immune response to our cells in any of our animal models. Part of that, we believe, is due to the change in the HLA surface markers that occurs through the culture process. So these are the things you've got to do if you're going to go from science project to something that we can actually use in people. And of course, our goal is to use these in people. Where we get the cells now, so this work started a decade ago with disc from my surgical patients, and you could use that as a source. It's not, as maybe the ideal source. So we actually use human organ donors, and so and we have a certain age range. We have donor criteria, but no one uses the disc. The people use hearts, they use livers, all the various tissues that get transplanted while there's still, circulatory function in the brain dead patients. We go in and take the disc, and it's that population of cells that we expand in our lab to produce discogenic cells. So we have a plentiful population, and we've had some of these cells alive now for almost a decade. So they're not immortal, but they do last a while. So all of that activity, which has gone on over years, finally is culminated in a human trial. It's a combined phase 1 and 2 human trial. Here in the United States, we're just getting the Japanese trial ramped up, and that should start this summer. It's a multi-site trial. One of the sites is here in Santa Monica. Dr. Tim Davis, who's interventional and pain management physician here, is the PI. But we've got a dozen clinical sites across the country. It's a 60-patient trial. Patients have to have single-level degenerative disease. And there are 4 cohorts. We're testing 2 cell doses, and the cell doses are derived from our animal studies. And we simply looked at the volume differences between the animal model and the human disc. You have to do some guesswork here to derive what the human cell doses ought to be. So we've got a low dose of 3 million cells and a high dose of 9 million cells in the study, and then the vehicle control. And then the patients are being followed out to 24 months. We've just enrolled our 15th patient yesterday, actually in North Carolina. Tim, I think you did one this week. And through FDA regulations, as Linda knows, you have to have a data safety and monitoring committee. I cannot be involved in the study. I got to be involved in the basic science, but I'm not in the study. I'm too conflicted. And I'm not on the data safety and monitoring committee either. But our DSMC, we had a stop a couple of weeks ago. They'll stop your study from time to time to make sure there are no adverse consequences. They want to make sure these things are safe. And so far, we haven't seen any safety events, thank goodness. But still early in the trial, and the goal here is to get what's called a BLA, a biologic license application. And so this phase 1/2 trial ultimately will have to be followed by a phase 3 trial. But so far, interesting. We're obviously encouraged by what we've seen in the animals. We'll see what happens in the humans. Time obviously is going to tell, but the science is good. It's good science. So in conclusion, there's an interesting and complex pathophysiology to this relatively common issue of degenerative disc disease. And the science, I think, it's expanded enormously, at least over the past 10 to 20 years. Cell therapies may be a way to treat this entity, and the discogenic cells are a potential solution for that. If in my clinic, one of my most frustrating patients to deal with is the patient with back pain that's mechanical in nature, who has degenerative discs. We know fusion isn't the answer. We know disc replacement is, so-so in the low back. And so we need a better answer, and my hope is that we're moving toward one. Again, time will tell. Thanks very much.